In Litwak et al. In 2019, a retrospective cohort observational study, they evaluated the effects of triple therapy on clinical practice. 94 adults on vasopressor support and with septic shock were included. The treatment group, which was half of them, 47, received IV vitamin C, 1.5 grams every 6 hours, 200 milligrams of thiamine every 12 hours, and 200 to 300 milligrams of hydrocortisone daily. The control group received the standard of care and hydrocortisone only if it was indicated. No difference in hospital mortality between the groups was seen, and no difference in vasopressor independence between the groups was seen. In Merrick et al. In 2017, a retrospective before and after clinical study, they compared the outcome and clinical course of septic patients treated with IV vitamin C, hydrocortisone, and thiamine during a 7-month period. 94 adults were included. The treatment group received IV vitamin C, 1.5 grams every 6 hours, thiamine 200 milligrams every 12 hours, and hydrocortisone 50 milligrams. The control group received no supplementation. Hospital mortality was found to be 8.5% in the treatment group compared to 40.4% in the control group, which was a significant difference. In Luger et al. In 2015, it was a double-blinded, randomized controlled pilot study used to identify if thiamine supplementation would increase blood concentration of thiamine and reduce blood lactate concentration post-op. It also sought to identify the prevalence of high serum lactate concentrations. 30 adults were included. The treatment group received 300 milligrams of IV thiamine in normal saline. The placebo group received just normal saline. The thiamine group had significantly higher serum thiamine levels 2 days post-op. The mean lactate changed significantly over time, but not between groups, and 10% of the patients were found to be thiamine deficient at admission. In Holmberg et al. In 2018, a retrospective cohort study, they investigated the practice patterns in thiamine administration in patients with alcohol use disorders and septic shock. 53 adults were included with elevated lactate over 4 millimoles per liter and alcohol use. The treatment group received IV thiamine, 100 milligrams within the first 48 hours of admission. The control group received no thiamine. Mortality overall was found to be 57%. Significantly lower mortality rates were seen in those who received thiamine compared to those that did not. Chang et al. In 2020 was a single-blinded, randomized controlled trial. They looked to evaluate the efficacy of hydrocortisone, vitamin C, and thiamine combination treatment for patients with sepsis or septic shock. 80 adults with sepsis or septic shock were included. The treatment group received IV 50 milligrams of hydrocortisone every 6 hours, 1.5 grams of vitamin C every 6 hours, and 200 milligrams of thiamine every 12 hours. The control group received no supplementation. No difference in mortality was observed. Lactate clearance, however, was found to be higher in the treatment group after 72 hours compared to the placebo group. Unfortunately, this finding was not significant. The final study of this review is Fuji et al. In 2020. It was a randomized, open-label, parallel control, multi-center trial. They sought to evaluate if vitamin C, hydrocortisone, and thiamine led to more rapid resolution of septic shock. 211 adults with lactate over 2 millimoles per liter and diagnosed with sepsis were included. The treatment group got IV 1.5 grams of vitamin C every 6 hours, 200 milligrams of thiamine every 12 hours, and 50 milligrams of hydrocortisone every 6 hours. The placebo group received the hydrocortisone only. Time alone and vasopressor-free days were not statistically significantly different. Improved SOFA scores, however, were significantly greater in those in the treatment group. So now that we've gone through and talked about the literature, let's draw some conclusions. 6 studies in the review saw a decrease in lactate levels or increase in lactate clearance with thiamine supplementation. Byerly et al., for example, examined both vitamin C and thiamine combined and thiamine independently as an intervention and found even the thiamine independent supplemented group was associated with improved lactate clearance. Danino et al. Similarly found lower lactate levels at 24 hours and over time in the thiamine supplemented group, which was significant compared to the placebo. While no correlation was seen between thiamine and lactic acidosis in some of the studies, when a multivariable regression analysis was performed in the Danino study and the confounding variable of liver dysfunction was accounted for, there was statistically significant negative correlation found between thiamine and lactic acidosis that was not seen prior to the regression analysis. This leads to the question of whether other studies that found no significant relationship between the two variables would have seen them if some of the other comorbidities were accounted for, specifically those related to liver function. Additionally, thiamine deficiency was found to result in higher serum lactate levels due to pyruvate being unable to enter the Krebs cycle and thus being converted to lactate in higher quantities than would have normally been the case. Another study showed this inverse relationship between thiamine levels and both pyruvate and serum lactate levels. The idea was further supported by studies showing a significant difference in means between medium lactate levels in thiamine deficient versus non-deficient groups, and thus a significant inverse association between lactic acid levels and serum thiamine levels. If low thiamine levels are thus associated with higher lactate levels, it further supports the possibility that higher thiamine levels, possibly with the use of IV thiamine supplementation and/or correcting existing deficiency, may be associated with lower lactate levels, which would be ideal for a quicker improvement of sepsis and critical illness and better overall outcomes. Overall mortality within the studies was found to be significantly improved by thiamine supplementation in 7 of the articles. Some of the articles did not examine mortality as an outcome, while others found no significant differences with thiamine supplementation. Should some of the other studies examine this as an outcome, more than 7 out of 18 may have shown positive results in this category. Even in some of the studies where there was no significant difference between thiamine supplementation and lactate levels in sepsis, an improvement in mortality was still seen. This is interesting because lactate levels were found to be an independent predictor of mortality with or without thiamine supplementation. A promising result from Merrick et al. Found that hospital mortality rate to be only 8.5% in thiamine treatment groups compared to 40.4% in control groups. All of these patients in the thiamine treated group additionally survived their ICU stay. In addition to septic-only patients, thiamine supplementation was found to improve mortality rates in other critically ill groups with sepsis, such as those admitted with alcohol use disorders or diabetic ketoacidosis. This may show potential implications for use of thiamine in other septic subgroups for mortality benefit as well. Some of the studies reviewed assessed thiamine levels at baseline for potential deficiency. One study identified as high as a 71.3% deficiency rate in their participant population, while others found 10%, 25%, 29%, 35% deficiency rates at study inclusion. Thiamine deficiency was not found to be affected by insulin therapy, however, was noted to have a high prevalence in DKA populations in addition to septic patients. Thiamine deficiency was hypothesized by many and concluded by some of the studies reviewed to affect mortality, specifically in the ICU. Unsurprisingly, thiamine concentrations in studies examining before and after values increased in the thiamine supplementation groups, especially when they were already deficient at baseline. Interestingly, one study also reviewed that there was a high number of patients qualifying for thiamine based on current practice recommendations that did not receive it at their facility. This unfortunately may have contributed to selection bias, but also lends to the larger issue of not only a high prevalence of thiamine deficiency, but also the potential for high prevalences of untreated thiamine deficiency, which could worsen outcomes in sepsis based on some of the associations seen in this review. Additionally, thiamine supplementation has a low risk of side effects and contraindications. This low risk of supplementation, compared to the high rate of deficiency and possible positive benefits of supplementation, shows another reason why supplementation should be considered in these septic patients, even currently while research remains mixed. Limited side effects mentioned in the studies included hypernatremia, which is an elevated sodium level. However, the mentioned side effects were mostly due to the solutions that thiamine was being administered in, such as the normal saline or the D5, or other parts of the combination therapy, such as the steroids, not necessarily related to the thiamine itself. Some strengths of this review and the studies included similar intervention doses and all administered thiamine intravenously versus orally. The review included 7 randomized controlled double-blind studies, which are considered the gold standard for research design. Additionally, while all the studies included lactate and/or mortality as outcomes and included the patients with septic shock, specifically those with hyperlactatemia, they further explored other critical illnesses and comorbidities such as DKA, infection, and alcohol use. This is important in the determination of whether lactate and mortality improvement with thiamine supplementation in sepsis is limited to certain categories of critical illness and diagnoses, or if it can be effective in a wider range of critical illness as long as patients have sepsis and elevated lactate levels at admission. Unfortunately, the studies reviewed did have several limitations. Many of them included their observational design, and most noted small sample sizes as limitations. While small sample sizes are not always a limitation, in these studies they were noted in the discussions to be one and possibly a reason why significance in the results was not seen, and it lent to a higher risk of type 1 error. Additional studies with larger sample sizes are important to continue to explore these relationships and better assess significant associations that may not have been able to be seen in the current pool of research. Sepsis criteria is also broad, and thus different facilities or physicians can diagnose it with different components of its definition, leading to the possibility of different populations and different diagnosing patterns and treatments in study locations. Additional limitations of the studies reviewed include sicker populations, lack of control groups, comorbidities not accounted for with multivariate regression analyses, and side effects of medication and intervention, sometimes stopping the treatment early. Finally, having only one reviewer for the systematic review may be another limitation. In conclusion, thiamine was not consistently shown to improve lactate levels or mortality. However, more than half of the studies showed significant or trending inverse relationships between IV thiamine supplementation and serum lactate levels and IV thiamine supplementation and mortality in critically ill patients. More randomized, double-blind, placebo-controlled, larger studies are needed to fully assess this intervention and its potential benefits in sepsis. Potential research gaps of the studies included effects of normal saline and D5, which were typically used as the vehicle for the thiamine administration on sepsis and lactate. Doses in the studies ranged from 100 to 300 milligrams per day, but larger and longer supplementation of thiamine remains unknown still in current research. One study reviewed determined that a 4-day course of treatment was all that was needed for optimal results. However, this was not specifically evaluated or discussed in any of the other studies. Future research could also focus on trials with higher doses of thiamine supplementation, safe upper limits for supplementation without negative side effects, optimal time period for supplementation, the difference in lactate improvement with varying degrees of thiamine levels at baseline, and more studies on the effects of thiamine supplementation alone on sepsis and lactate versus combination therapy with vitamin C and/or steroids. Implications for practice are still inconsistent. Unfortunately, this review showed mixed results on thiamine's effect on lactate levels and mortality in sepsis. However, minimal negative side effects were identified throughout the studies from thiamine supplementation, and it is inexpensive, suggesting that it still could be used in practice, pending continued studies to support its consistent use as a standard of care, as well as specific dosing and timing recommendations. Many of the studies have alluded to the goal of early thiamine supplementation during critical illness being possibly more effective than later in admission supplementation, and this is another important area to continue to research for application in acute patient care. Also, as previously discussed, high rates of thiamine deficiency in critically ill patients have already been seen, and potential benefits are high, as seen in the studies reviewed today, combined with relatively low risks of supplementation, further supports the use of this in clinical practice pending further research to prove or disprove its effectiveness. There is no funding, potential bias, or conflicts of interest to disclose for this systematic review. And here are my resources. Thank you for listening.